Welcome to the Patient and Family Engagement in Care for Persons with Mental Health Concerns webinar. My name is Ellen, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Jane Gendron. You may begin.
Thank you, Ellen. Hello, everyone. This is Jane Gendron. I'm a program manager at Status Health, the Minnesota organization that's part of the Lake Superior Quality Innovation Network, or the Lake Superior QUIN, as we call it. The Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin, and we're under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I'd like to welcome you today to this educational session entitled Patient and Family Engagement in Care for Persons with Mental Health Concerns. Today's webinar is part of an initiative funded by CMS to address access to behavioral health services. The Lake Superior QUIN is currently working with more than 600 clinics throughout the upper Midwest to increase screening of behavioral health needs during primary care visits. Our goal for today's discussion is to increase the effectiveness of screening by gaining an understanding of how stigma keeps patients from disclosing their struggles and keeps those of us in the healthcare system from reaching out in a compassionate way to ask about them. As Ellen mentioned, all lines will be muted during the webinar, but we will have time for question and answer at the end of the presentation. And you can also add any questions that you have in the chat. We'll be monitoring that, and we'll be addressing those questions at the conclusion. So our speaker today is Sue Abderholden. Sue is the Executive Director of the National Alliance of Mental Illness of Minnesota. She's worked for PACER Center, ARC, and U.S. Senator Paul Wellstone. And over the last 25 years, Sue has successfully fought for community and family support and for laws that enable people with disabilities to fully participate in society. She understands the isolation that is caused by discrimination and stigma and has devoted herself to empowering people to come together to create change. I'll turn it over to you, Sue. Thank you.
Thanks so much for inviting me here today. And good afternoon or good morning to all of you. I'm making sure I can turn this here. So one thing to just start off with is that mental illnesses are very common. The new data show that 1 in 5 people will develop a mental illness during any given year. What's really important to understand is this is actually a young person's illness. We often think about mental illnesses in terms of adults, but we forget about them in terms of children. 50% of adults began experiencing symptoms by the age of 14 and 75% by the age of 26. So you can understand why it's important. We really have focused on screening for adults, but we need to think about screening for children as well. As with many illnesses, there's a range of severity. So you can have a mild form of depression or a very severe, serious form of depression. And the mental illnesses impact on functioning ranges as well. So someone may still be able to work and do all those kinds of things fine and may just have some low times during the year, whereas someone else may be impacted so greatly that they're actually not able to work or maybe not able to care for themselves or their children. As with any illness, we know that early identification, early detection, and intervention yields the best results. And unfortunately, we have not done that very well in this country. So people live with their symptoms an average of 10 years before seeking help. And even a young person experiencing their first psychotic episode, it's an average of 74 weeks. There's many reasons for the delay in seeking treatment, stigma and public attitude certainly being one, but also the inability to obtain treatment. We also know that in our mental health system, we often have not provided the level of intensity that's needed. I kind of liken it to saying if your doctor told you that you had cancer, they wouldn't say come back when you had stage 4. But that is what we do in the mental health system. We don't provide intensive services until someone has been hospitalized numerous times. The other thing I wanted to mention is that many mental illnesses can be treated in primary care. Primary care treats a range of illnesses, and yes, when something gets severe and complex, that's when you bring in a specialist. But again, because not every mental illness is alike, not everyone needs a psychiatrist. Not everyone, needs a specialist in terms of mental health. So again, many people can be treated very successfully in primary care. Now, access to treatment has been difficult, and I think it's important for anyone working in primary care to understand this. Often we hear from emergency rooms and even primary care saying, well, we're not supposed to serve those people. They should be in the mental health system. And the reality is that there's been a lot of discrimination in terms of building our mental health system. So I think everyone understands that private insurance has not fully reimbursed mental health treatment, particularly when it comes to, while we have mental health parity laws, mental health parity just says if you cover mental health and substance use disorder treatment, you have to do it in the same way, but it doesn't actually require coverage. Even then, in terms of the same way, we know that many insurance plans will actually pay for someone's rehab in a nursing home after they get a new hip, but they don't pay for residential treatment after someone perhaps with schizophrenia leaves the hospital and needs rehab. And there's very few plans that cover in-home intensive services. So there's a lot of discrimination under private insurance. Public insurance actually discriminates as well. Medicaid does not reimburse for any services that are provided in what they call an Institute for Mental Disease, which is any facility that has more than 16 beds where over half of the people are being treated for mental illness. So it never paid for institutional care. It doesn't pay for things, for those of you in Minnesota, and that's a Metro Regional Treatment Center. Medicare also has a lifetime limit on the number of inpatient psychiatric bed days, and it does not reimburse for all types of mental health professionals. So the reality is you can't build a mental health system or a healthcare system using block grants. You need to have insurance paying for it, and because we did not have insurance paying for mental health treatment, there really weren't a lot of dollars done to build a system. I often hear from people that the reason we don't have a mental health system or the reason that we have so many people with mental illness in the criminal justice system is because we closed the institutions. And I do want to just remind people that the institutions were actually a problem. They were, frankly, not great places for someone to live and often the treatment wasn't great as well. And so closing the institutions, which really actually happened all the way back when President Kennedy was alive, was not the problem. The lack of funding for community services was. So NAMI likes to say that we don't have a broken mental health system. The reality is we never built it. So moving on to other barriers to treatment other than not having insurance pay for it, our societal attitudes are really a major barrier. When the U.S. Surgeon General put out his first report ever on mental health, he said, we can look at insurance discrimination and the fact that we don't have mental health providers, but the largest barrier is actually stigma. So the way that stigma impacts us is I go out to what I call animal groups, so lions, moose, Rotary clubs. And when I ask them, close your eyes and picture someone who's living with a serious mental illness. And I ask them what they pictured. It's typically someone who's older, who looks like they're homeless. They may be wearing, a heavy coat in the middle of July and talking to themselves. It is never a positive image, and it's never anyone that looks like them. So when you can't relate to that and, your picture of someone with a serious mental illness isn't anyone that looks like you, it's much easier to marginalize them in our communities and society. Words have a huge impact. I think you can ask any author, you can ask any civil or human rights movement about the importance of the words they use. If I was, there present with you, and I would ask you actually to shout out all of the slang words we have for mental illness. Psycho, nuts, crazy. We have a lot of them. But what slang words do we have for other illnesses, like heart disease or cancer? We don't have them. And while I'm not trying to be the word police, we kind of minimalize the impact on of mental illnesses. And it also prevents people from saying that that's what they have, because they don't want someone to say that they're crazy or nuts. So words actually are huge. Another way to think about words are, when we talk about someone who has cancer, we talk about how courageous they are. Maybe someone who has enough, how determined they are. Have we ever used those words for someone who has a very serious mental illness? And I would say that it takes a lot of courage for someone who has schizophrenia to leave the house in the morning, go to a job, get on the bus. Someone who has serious depression, it takes a lot of determination to get out of bed, care for your children, get to work. And inspirational is also another word, and yet there is a lawyer actually in California. She was a MacArthur Genius Grant winner, and she lives with schizophrenia, and I would say that she is very inspirational. And the other word that I would just use is nonviolent. Unfortunately, if you focus just on the media portrayal of people with mental illness, including on TV shows, they're often portrayed as more violent than any other TV characters and then in real life. That actually less than 4% of the violent crimes committed in our country are committed by someone with a serious mental illness. So again, because of stigma, that leads to the delay in treatment among people with mental illness. So I wanted to just show you a couple of slides to kind of really think about it. This is an actual donut shop in California called Psycho Donuts. You can see the bipolar donut has chopped nuts on one side, coconut flakes on the other. Of course, NAMI out there in California did protest what they were doing, but they said, free speech and you can go to any other donut shop. But for the families there, they talked about, how difficult these illnesses are, and making fun of them really doesn't help anything. There was a company that put together a couple of slides to try to help us understand how we might be treating mental illness differently than other healthcare issues. And you can see from the first one, I don't think it's healthy that you have to take medication every day just to feel normal. Don't you worry that it's changing you from who you really are. And we would never say that to someone who has diabetes and is taking insulin, but we do know we say that to people with mental illnesses all the time. You can see the second one, it's like you're not even trying. How many times have we said that to someone living with depression or anxiety? Probably quite a bit. And yet we would never say that to someone, of course, who's bleeding. And the next one you can see, I get that you have food poisoning and all, but you have to at least make an effort. Again, we would never say that to someone who really has food poisoning, but we do say that to people who have depression, bipolar disorder, and anxiety. And then lastly, while lying in bed obviously isn't helping you, you need to try something else. And I think you can again see that you would never say that to someone who is experiencing that in a hospital setting, but yet we do say that to people with mental illnesses all the time. So the problem, of course, for our society is that when we delay treatment and when we don't identify people early, it has not just an impact on the individual and their family, but on our community as a whole. So we do have people ending up in the criminal justice system, not for violent acts, but for kind of more nuisance crimes, and they end up in jail instead of getting treatment. We have a lot of people who are unemployed because of their mental illness, partly because employers often don't know what accommodations are for mental illness. Youth with mental illness have the highest dropout rate. We know that people who are homeless have a high rate of mental illness and substance use disorder. Isolation is huge, and there's been a lot of stories recently in the press about the impact of social isolation on someone's health. And of course, it has a huge impact on mental health. And if you're feeling very depressed, of course, you're not going to reach out, but people don't reach in. And then there's high rates of suicide, which are directly related to untreated mental illness. And unfortunately, the rates of suicide have been rising, not only in Minnesota, but across the country. Around 2001, our suicide rate in Minnesota was around 200. It's now around 700 per year. And so that, of course, has a huge impact on families and our society. This is SAMHSA's Wellness Recovery Wheel. And I think it's important because often when we think about, someone with mental illness getting better, all we look at is the absence of symptoms. And what we really need to look at is the whole person. So it's not just the absence of symptoms. What's their environment like? Because they have too much on their plate and it's too hard to get things going, does it look like a hoarding environment? Are they living below the poverty line? Are they exercising? How's their nutrition? Are they connected to other people? Do they have a reason to get up in the morning? So we really need to think about all of those things when we look at recovery for someone with a mental illness. So when we look at recovery, we know that certainly early identification is best, getting access to treatment right away. Often what we hear is if someone wants to get a psychiatrist, even today, it's at least a 3 to 6 month wait. And I want you to think about someone who maybe is experiencing their first psychotic episode. We do not want them to wait 3 to 6 months. Again, taking a holistic approach, so not just giving medicine, but making sure they understand the importance of therapy, the importance of exercise and diets and things like that. And then the engagement of the person and their family. I want you to think again about the isolation of mental illness and how important it is that people are connected to others and they have someone who can help them through this. So one of the things we hear all the time is that people are expected with a serious mental illness to get through the illness by themselves. Typically, we have mental health professionals or healthcare professionals who are not asking them, is there someone else that can be here with you? Who's your emotional support? We have many people who are discharged from the hospital without anyone else in the room. And just thinking about the symptoms of mental illness in terms of memory loss, not being able to remember things, difficulty concentrating, it's not a surprise that people then are readmitted in a short period of time. We all know from just regular healthcare issues that people can't manage their illness well if they don't really understand the treatment plan. What we have found is that often people do not get information, frankly, about their treatment plan, which does make it hard for them to follow it. Our national office just came out with a study that found that over 70% of people do not come back after their first or second visit with a mental health professional. And what that says to me is that we have not engaged them well in terms of that first or second visit. And of course, we want that not to be their last visit. We want this to be, part of their entire treatment plan. So now just talking about depression screenings. This is really hugely important, and I do appreciate every time I go to my primary care office and they actually ask the PHQ-9 questions, because then I know they're really focused on this. It's important for a couple of things. One is that it raises the issue with every patient that comes in. And while it's a depression screen, some of the symptoms of depression can actually be symptoms of some other mental illness. So it still will give you an idea whether how that person's mental health is doing. The other thing that it does is it opens up the conversation. It opens up the door to actually talk about mental illnesses, which is really important because people need to feel comfortable in order to do that. So just asking about it actually makes it okay. So we're going to talk a little bit about the symptoms of depression. So we often understand someone might be sad, right, or anxious, kind of an empty mood. We get that with depression. It's the other things that we might not see. So certainly the feelings of hopelessness or pessimism, the world's a bad place, I'm not going to get better. But irritability is a huge part of it. Now, especially with teenagers, that's what we see more than them being sad. And I know most people will say, well, how can you tell in a teenager whether they're, whether they have depression or they're just, being a teenager. And what we like to talk about is really the length of time and the intensity. We all get crabby from time to time, but someone who is constantly irritable when they hadn't been that way before, that really could be a symptom of depression. The other thing we see is that people stop liking or doing what they used to enjoy. Whether it's, someone who used to golf and no longer does that, someone who used to have a book club and no longer does that. And so when people, whether it's a teenager or an adult, starts moving away from the things that they used to like to do, that's also a very big sign. Having decreased energy or fatigue, so really sleeping more or sleeping less than they used to, always feeling tired, those again are very true symptoms of depression. We also have people said that they actually move more slowly when they're very depressed. It feels like kind of those old woolen blankets, that maybe have been soaked and is just very heavy. They actually feel that weight on their shoulders. And then also just feeling restless or having trouble sitting still, which you can imagine would be not a great thing in the classroom for a teenager, but it can also impact your ability to do well at work, but that is also another symptom of depression. Difficulty concentrating, remembering, or making decisions is another piece of this. Again, think about the impact that could have on someone's employment, the sleeping issue, appetite or weight changes, either eating too much or eating too little. Thoughts of death or suicide are really important as well to really listen to. And then the other thing is that our head is actually connected to the rest of our body, and so we often see, particularly in culturally diverse communities or in children, it's coming out in a physical way. So if someone has headaches or stomach aches that, can't be explained, that, clearly don't go away, or, maybe treatment is tried and those things are still there. So all of that can still be a symptom of depression. Now, depression appears differently among different people. So usually in women, we actually see depression being a little bit higher there, but often it's due to hormonal factors. So many times women during menopause experience depression. Teenagers, when they first get their period, actually can also experience depression. We know about postpartum depression for women who are pregnant or who are new mothers. In men, we see that they're actually usually more irritable and angry than when women experience depression and often have more sleep problems. In older adults, we really like to remind people that depression is not a normal part of aging. And so, yes, they may be feeling grief because they're losing their friends or, perhaps their, spouse or partner, but it still shouldn't go on forever. And we know that they also develop other types of illnesses during this time, like heart disease, stroke, diabetes, and often those illnesses, depression is co-occurring, and sometimes the medications actually contribute to depression as well. And then in children, we see a couple different things. School refusal is huge. And as many of you know, depression and anxiety often go together, so a child is very nervous about going to school and anxious, and so that can actually be a sign of depression. And in teenagers, it can be that they're maybe getting in trouble at school and, of course, being irritable. There's treatment, again, is not just a pill, and medication is usually only used when there's more serious depression. There's certainly been some studies around there. Psychotherapy is really very important, and again, that doesn't have to be a psychiatrist. It can be a psychologist, a clinical social worker, licensed marriage and family therapist, a professional clinical counselor, and they can really help the person view things differently and deal with stress and anxiety in a more healthy way. And one way to think about it, cognitive behavior therapy is certainly an evidence-based practice for depression, if it helps you think about something different. So, for example, a teenager who doesn't do well on a test, if they have depression, they might come home and say, it's because I'm stupid, I'm a horrible person, I'm not intelligent at all. With cognitive behavior therapy, they can actually look at it more objectively and say, well, maybe I could have studied differently, maybe I could have done this differently. So instead of really putting themselves down, they look at the environment and how they might have reacted differently. We know for people who have where medication has not been effective, we know that ECT and now transcranial magnetic stimulation also can be very effective methods for treating depression. We do want people to think about diet and exercise. When we've been asked, well, what can I do, for a friend or family member with depression, we always say take them around the block for a walk. Moving, especially walking, can really help the endorphins in the brain and help people feel better. Staying connected to others is really critical because it's really easy to isolate yourself. There's been a lot of work around the impact of things like mindfulness training, meditation, and yoga, really helping someone with depression and anxiety. We also try to get people to think about not drinking during this time, certainly not taking, drugs or, marijuana or anything like that. Too much caffeine can really interfere with their sleep. And smoking and mental illness, unfortunately, often go hand in hand, but it can actually impact their ability to absorb medications. So we'd like to really promote smoking cessation as well. And good sleep, really critical. We love to hear when high schools delay the start time because teenagers really need sleep, and that is a key time when they develop depression. So really stressing the importance of sleep with any patients is important. So the barriers can be great. People don't want to necessarily talk about the fact that they have depression. Some of it, again, is because of stigma and how we view people, but also afraid if I tell someone, how could that impact my job or if I'm in school? People honestly don't really necessarily know a lot about depression and the fact that people can get better and what are the different treatment options. Certainly, financial, if your insurance isn't paying so much or will only pay for a limited number of visits, that can be very difficult as well. It can have an emotional impact on the entire family because, in essence, you might have someone who's really not there to help you, through the normal kind of day-to-day things of life. Time and transportation. A normal kind of round of therapy, especially, for example, for a teenager, would be about 20 visits. Not every family can take off once a week for an hour or so to pick up the child from school, drive them to the therapist and drive them back. Often they don't know what to ask if they're not feeling well, so that's why the depression screening is so important. And a lot of people actually don't know who a mental health professional is. You know, they might refer to, well, a therapist, but what does that mean? And people really should look at, you know, what kind of license does that individual have? What kind of therapy are they providing? They really need to ask those good questions. We like to have patients really do more asking, frankly, in primary care or with mental health professionals, for them to think about, you know, so what are the symptoms I've been experiencing? You know, what are the risks and benefits of any type of medication? What are the side effects? And as you know, they often list quite a few different side effects, but people need to know about them and to really talk about which medication has which side effects that they might be more willing to do. Knowing about therapy is important. Again, it's not just counseling, cognitive behavior therapy. We need to really give names to these things. People often stop taking their medication for many illnesses, but particularly for mental illnesses when they start feeling better. But with many of the medications, of course, they shouldn't just stop right away. They need to be titrated off, and so making sure that people know that is important as well. Patients should ask what else they can do to recover more quickly, and what can their family do to support them. And families are often told really kind of ridiculous things that won't be helpful, like, you know, using tough love and things like that, which frankly, tough love doesn't work for epilepsy, and it doesn't work for mental illness. I want to make sure that people know some of the warning signs related to suicide. Because the suicide rate has gone up so high, we think everyone really needs to know about this. So certainly if someone's threatening to hurt themselves, you know, that needs to be taken seriously. Perhaps you have a teenager writing a lot of poems about death, that needs to be taken seriously. Someone feeling hopeless, no thoughts about the future being any better. Sometimes someone being, you know, having that uncontrolled anger. Certainly engaging in risky activities, because in a way that could be a suicide attempt, so driving a car fast or a motorcycle or something like that. Feeling like there's no way out of the situation. It's just going to keep getting worse. Increasing alcohol or drug use, because we kind of call that self-medicating. Withdrawal, certainly, from friends, family, or society. Someone who really is either sleeping all the time or not able to sleep. Real dramatic mood changes, and often for the better. So what we often find is that someone who's been feeling extremely depressed and suicidal, they make the decision actually to take their own life, and then they feel relieved and they're happy. And so a very dramatic mood change in a very short period of time is actually reason for concern. And then obviously not seeing a reason for living. And the purpose of life is another huge warning sign. And so these should be taken very seriously. And I would also say to any family member who's, you know, in on that visit, making sure they understand what the warning signs of suicide are is also really important. And a couple of things about safety. There's actually an evidence-based practice called means restriction education. And what they found is that teenagers who had a suicide attempt and were seen in an emergency room, that the families were not provided any information about how to keep that teen safe. And I think means restriction education can go way beyond children and teens and to all adults as well. And what it means is teaching people how to restrict access to lethal means. So certainly if someone's on an antidepressant, there shouldn't be guns in the house. They need to remove them, not just lock them up. Most people know where that key is left. We also have to make sure that over-the-counter and prescription drugs are actually locked up in a small safe. It can even be like a little file cabinet, but where a key is used and not a number. Every teenager will know what number you use on that lock. And so having the key and keeping it, and the family knowing they have to keep it with them, is really important. Again, educating about the warning signs, and then making sure that families know what to do if they really are concerned that someone is feeling suicidal. Minnesota has a mental health crisis line in every single county. Most counties actually have a mobile crisis team. We have been pushing healthcare systems that actually have urgent care to add mental health professionals or access to it through telemedicine through each of those, knowing that they certainly should bring someone to the emergency room. And of course, some hospitals have a psychiatric emergency department, which is actually a little better than a regular one because there's, reduced noise and things like that. So the safety, again, is really important in all of this. And NAMI did a survey of people who've been hospitalized just to find out how they felt they were treated. And one of the things that we found is that few people get well cards. I was surprised that it actually came up to 25% when I first came to NAMI 15 years ago, and I'd asked people with a serious mental illness if they ever got a get well card when they were hospitalized. They all said no. But still 25% is not very much. You can see visits from family was 86%. Families play a huge role, but often they feel very pushed out by the system. Visits from friends was 45%, but having an easy time staying connected is 34%. And I think if anyone's been in a psychiatric unit, there are rarely phones in people's rooms. And so there's a phone in the main area, and so again, it's very hard for someone to call in and leave a message or talk to someone who's hospitalized, but also difficult for people to reach out. We really want healthcare and mental health care professionals to understand that families are very, very important in all of this. Families are really the safety net for someone who has a mental illness. We're the ones that try to help them. We are the canaries in the coal mine. We know when someone's mental health is starting to deteriorate before anyone else. We keep the records. We know the person's history. We also know their strengths, talents, and preferences, which I think is important. We're also the advocates for the person. We're the ones that are filling out the insurance company forms. We're the ones that are making the calls. We also offer a lot of practical help. So if someone's lost their job due to their mental illness, we become the transporters. We provide the money. We provide the food. We take them back into our homes. So families actually play a really essential role that often actually kind of feel pushed out in all of this. Now, I like to sometimes say that, I missed the slide there. So family engagement is really important. So again, just thinking about the symptoms of someone with a mental illness, difficulty to concentrate, all of those kinds of things, it's really important to seek the history from a family member as well. And you don't need a HIPAA signed release to do that. Talk to them about, well, how has it been going? What have you seen? What do you think needs to be changed in the treatment plan? Make sure that they know what to do and say, well, if this keeps happening, then you're going to need to do X, or if this happens, you need to do Y. Making sure there's really clear, open channels of communication. The other thing that people really, and having come from the disability world, what people have not given to families who have a loved one with a mental illness is understanding that feeling of loss. I want you to think about you had a 20-year-old that was in college, they had this past, going, and then all of a sudden, they had their first psychotic episode. And your dreams for your child at that point are very, very clear and distinct, and now they're gone. And there's loss involved in that, but often these families get very little empathy or sympathy. The words that we really hate to hear as family members are things like enabling, codependency, denial, rock bottom, dysfunctional, and hopeless. When you have a loved one with any serious illness, I don't care whether it's brain cancer, a severe developmental disability or a serious mental illness, you kind of look dysfunctional as a family because you're dealing with more than you can. And so I think we have to give families credit that they're hanging in there and that they're doing these things, and to really support them in this effort and recognize, again, that they need empathy and support in all of this more than most in some ways. One thing I'll mention is that while people with mental illness don't get well cards, families don't get hot dishes brought to them. This is a no hot dish illness, so they're not getting the support from the community like anything else. Now, I like to let people know that HIPAA does not require you to be stupid. So HIPAA is not so strict that you can't engage families. What we often found, especially if someone's hospitalized, is that no one's asked them other than one time whether they want to sign a privacy release. An 18 or 19-year-old comes into a clinic, if that young person came in for asthma or something else, they generally will talk to family members. If it's a mental illness, they won't. But also, no one's ever asked that person, will you sign a privacy release? So asking more than once is also important. You can even just ask, is it okay if I just share with your parent or with your family member what the diagnosis is and the treatment plan? Families do not want the actual written records. What they want to know is how they can help their loved one. You can provide general information, so you can say, well, typically a treatment plan for someone with depression includes medication therapy and, X, Y, and Z. So at least they have some information. And then if the patient's in the room, along with the family member, and they agree, you can have the discussion there without putting anything in writing. Families really feel that they can't win. So if they ask a lot of questions, and of course, the person may have been suicidal, they're really scared about what's happening, they're perceived as being overprotective. If they don't ask anything, they're unengaged. It's like you can't win. And what they really want to do is make sure that you have the information to best treat the person. We have some people who just believe that they're not sick, which is true especially with schizophrenia, but even with depression, they're not really seeing what the family member is seeing, because the family member knows what they were like before, and they know what's happening now. And so that information is always helpful to you. In Minnesota, we have a law that we passed called the Family Involvement Law, and it has been very helpful in terms of it's not as strong as HIPAA. So if you're a caregiver, there's actually a form that's been approved, and it's up on our website in Minnesota, which really allows you to provide more information to the family member. HIPAA also allows professional judgment. So if you think it's in the person's best interest, you can actually share that information. Especially when you're doing an evaluation, it's really important, again, to ask questions and involve the families from the beginning, and especially if you're leaving the hospital, to make sure they're involved in discharge planning. With patient engagement, a big thing is partnering with them on decision making. It's really talking through the different types of medications, the pros and cons of them, making sure that they know what their goal is. Is the goal to get back to work or to get back to school? What do we need to do to make that happen? And to make sure they have the information in order to make decisions. Making sure they have handouts about their illness or the various medications. And again, asking them, do you want others involved in this decision making? Who else would you like to be in the room? Make sure that they have a support network. Again, people can't get through a serious illness by themselves, so ask them about that. Again, making sure they understand their illness, their treatment plan, and involve them in changes in medication. I had a friend of mine who lives bipolar disorder. She was a very successful executive director of a large nonprofit, and she went into the hospital every now and then. Despite really following her treatment plan, she became manic, and she went up to get her medication, and she said, well, these don't look like the pills that I have taken. These are new. And they said, yes, your doctor changed your medications. And she's like, well, what are they? Why didn't they talk to me? And so, again, I think it's important that people get involved, especially when we're trying to change medications. There is a thing called Trip Map to help people remember about patient engagement. One is really thinking about the problems, pressures, people, and priorities. So really, what is it that they are looking for in life? Researching the facts and possible solutions, identifying the options for them, really weighing the pluses and minuses for each option, doing action planning, and pondering the results of the decision. Sometimes people don't want to make the decision right then and there. Give them a week to look at it as well. Provided some information here about the National Suicide Prevention Line. I think it's actually a great idea to post that in your office. Actually having any information in an office about mental illnesses, and particularly depression, is really helpful, but making sure people know those suicide hotlines. We have a helpline here at NAMI, but it's non-emergency, so if a family really wants some help, be sure to give them that line. Again, we have a crisis line in every county, and most counties in Minnesota actually have a mobile crisis team as well. So I wanted to make sure that you knew also what NAMI does, and I know we have people from other states, but there is a NAMI in every state. So first of all, we provide a lot of education classes. It's not like you get this information in your high school health class. So we have a 12-week class that's offered around the country called Family to Family. It's now an evidence-based practice. It's actually taught by other family members, which really provides that empathy and support, but they really learn about what to do and how to help their family member. NAMI Minnesota also provides a one-day class called Hope for Recovery. It's held on a Saturday pretty much every month somewhere in the state of Minnesota. And it focuses on not so much on the different illnesses, because we find sometimes people have looked online for that, but on a method called LEAP, Listen, Empathy, Agree, and Partner, which really helps families especially when someone doesn't think that they're ill and doesn't need help. It really gives them coping strategies and ways to involve and engage their family member in treatment. We have a number of classes as well for families who have a child or teen with a mental illness. And we recently started a class for family members of someone who's experiencing their first psychotic episode. We have a number of booklets on our website to help families and, frankly, professionals navigate the mental health system, both for the adults and children, also if someone ends up in the criminal justice system, a booklet explaining what happens if you're hospitalized for a mental illness. We have one on data practices. And we also have one on first psychotic episode that is actually up on the National Institute of Mental Health website as well. And then there are different fact sheets, both on medications and the different illnesses that you're welcome to download and hand out. We do a lot of work around suicide prevention. You can come in and do a 1-hour QPR class, question, persuade, and refer, or the means restriction education class as well. We offer over 70 peer-led support groups, so ones for people who live with a mental illness are actually led by a person with a mental illness who's gone through special training, along with family support groups as well. We do a lot around public awareness. Again, we need to change the attitudes towards people with mental illnesses, and the way we do that is through a number of different programs, including the Make It Okay campaign, but also a program called In Our Own Voice, where someone who lives with a mental illness, usually done in pairs, comes out and they share their story of recovery and hope. We do a lot of legislative advocacy because we need to end the discrimination under our laws and make sure that we have funding to support people in their journey to recovery. And then we also have the NAMI Walks, which is the largest anti-stigma effort. There's no fees for attending. Of course, we love it when people raise money for us, but it really is a way to say, these are issues that we all care about. I'd like to invite you to support us in some way. We do need people to advocate for a better mental health system. As someone who's lobbied for many, many years, I can tell you the power of an individual's story. We have a lot of events. We have a research dinner coming up in February where we hear from the Department of Psychiatry at the University of Minnesota about what new research is telling us. We do have a newsletter. We have local affiliates. We have all of those kinds of things, and always, of course, opportunities to volunteer as well. And then I have our contact information up there. And I will mention that we do have a youth website as well that they can go to. It has a lot less words on it and more videos as a way to really try to engage youth in thinking about their mental illnesses as well. And with that, I think we can turn it over for questions.
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. Standing by for questions.
Great. Well, while we're waiting to see if we do have people calling in or getting into the queue, I'm not seeing anything in the chat, so did want to just offer to people that if you don't want to pick up the phone and you want to be able to put questions in, please do put that in the chat. Do we have I'm going to open it to the folks in the room here. Are there questions that we could ask Sue while we're queuing up?
Yeah, hi Sue, this is Janelle Shear. I work with Dana on this initiative. One question I had, and honestly, I was trying to think of questions and you answered them as we were going, but I would like to know more information about the support groups that are peer-led. You mentioned that there are 70 of those. Are they throughout the state? And just a little more detail on what is involved in those support groups.
Certainly. So we call them NAMI Connection, are the ones for adults who live with a mental illness. They actually meet weekly, kind of on the AA model, and they're carried out with 2 people who live with a mental illness, and they go through a weekend training so that they really kind of understand how to keep a group going, moving forward, helping people move forward in their recovery, and also if they get dealt with what we call hot potato, if someone is suicidal or something like that. We have two new groups for people who have a dual diagnosis of both a substance use disorder and a mental illness. One is at HCMC and the other is St. Joe's Hospital. They are around the state. We depend on volunteers to do this, so if we don't have a volunteer in a community, we don't have a support group. We have a special support group called Open Door for people who have anxiety or panic attacks. We have a young adult support group, so you have to be 16 and up, and it's, again, led by a young adult who's doing well with their mental illness. We also have different support groups for parents of children, and then, of course, one for family members, and we also have an LGBTQ support group as well, so that people feel that they're in a safe environment. And then we do have a small program called Kid Shop for a child. Usually it's, K through 8, sometimes middle school, depending on the child. And it's actually a way for kids who have a parent or a sibling with a mental illness to get support from each other as well through playing in that.
So are these available to folks all over? I'm thinking of rural communities as well, or is it more metro?
We have some in rural Minnesota, but we also just started two groups that are web-based. So you can actually sign in on your smartphone and join the support group from anywhere in the state of Minnesota. And all that information is up on our website.
And then I assume, since NAMI is a national organization and there's chapters in each state, that each state would have their own support group system.
That's correct. They will all have a family support group and a NAMI Connections group. We just have some additional ones outside of the national model. But yes, there will be some in every state.
Thank you.
We just have a question also coming in on the chat. And so you mentioned that older people sometimes have less obvious symptoms when they're presenting with depression. Could you talk a little bit more about how older people present with depression versus teenagers or middle-aged adults?
Sure. So for older adults, actually what we see a lot of self-medication. So, it's noon somewhere, right, or 5 o'clock somewhere, however that saying goes. So people are actually drinking more, which of course adds to the risk for depression. I think the real issue is that often we just assume that an older adult is going to be depressed because they're experiencing grief in their lives, but it could really be not just grief. It's really depression because of some other healthcare conditions that they also might have. But what we'll see is their inability to kind of get through the paper in the mail that's coming in. They might not want to go to any family events anymore. They're not reaching out and calling anyone. You open up the refrigerator and there's very little food in it. So all of those things might be signs that they're depressed. So you can often still see it if you're doing the PHQ-9. They're still answering the questions that way. But I think what we've seen is that healthcare professionals just say, well, of course they're depressed, they're older. And we shouldn't actually have that attitude.
We do have a question on the phone. It comes from Kate Holden. Please go ahead. Hello, your line is open. Did you have a question?
Thank you. That was answered by Sue. She just answered it now.
Okay, we'll release your line. Thank you.
So there is another comment. Perhaps you could talk just a little bit about that there is a PHQ-9 assessment that is specific for teens.
Yes, and we have very few people using it. What we've seen is kind of a reluctance in primary care pediatricians' offices in doing a depression screen. And we really think that's important, especially since that is such a key age for developing depression, anxiety, and other serious mental illnesses. And again, how we like to explain it to policymakers and even parents is a depression screen is like a thermometer. So it can tell you whether you're warm or fine, but it doesn't tell you exactly what you have. And so if someone has a high temperature, well, then we're going to dig deeper and try to figure out what's happening. And so that's how we like to explain it to families. It's really a good thing to have. And I think the other thing that we've seen, especially with teens, is that what might be happening at school is different than happening at home. So, for example, if you have a child with high anxiety but has a real strong urge to do well in school, they might keep it together in school the whole day, and then they come home and fall apart. And yet if the parent goes to school and says, what's happening? My child's falling apart, when they come home, and they're like, well, they're fine in school all day. The other thing that might happen is that a child does not do well in school and is having, a lot of irritability and anger issues, and they come home and they're fine because home is a safe place. Home has figured out how to adapt and support them, and the school has not. So I think it's really important to do that depression screen so that there's something a little bit more valid and we don't really know why, but people are usually pretty honest on those screening tools, and it really will help us identify those kids early. Kids doing poorly in high school all of a sudden is actually not normal and is often related to depression and anxiety. And again, we want to nip those things in the bud, give those young people the tools and strategies that they need to come out of their depression or deal with their anxiety. So it's just really important that they not go through those years feeling absolutely miserable.
Good. Well, I think, Ellen, do we have anybody else in the queue on the phone?
We have no further questions.
Okay. Well, I think that was a terrific presentation, Sue, and I feel like you really covered it very comprehensively and gave us some great information, so thank you very much. I'm going to mention to people that as you exit the webinar today, a window will come up giving you the opportunity to do a short evaluation. If you take a few minutes to fill that out, it will give you a certificate of completion at the end of that, and that's your only opportunity to get a certificate if that's what you need. So please do take time to do the evaluation. But thank you very much. This presentation was recorded, and we will be putting this up on the Lake Superior Quinn website in about 2 weeks. And thank you all for your participation today. Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating, and you may now disconnect.